Alaikum. Okay. First of all, I would like to thank the organizing committee to invite me to present this case. Mainly is a cardiogenic shock case with intervention mainly. So I have 66 years old male, came with 3 days history of progressive shortness of breath and left-sided chest pain relating to left arm. The patient has these symptoms for almost 3 months with progress at rest. After that, he has medical history of diabetic hypertension and hypothyroidism on medication. Arrived on 14th of October, just I showed the date to see the progress of the disease. So arrived on 14th of October walking by himself. He was having mild ongoing chest pain, blood pressure 105, heart rate 107, and also 93% saturation on room air. S1, S2 normal, and there is no murmurs, chest, bilateral lower lungs crackles, abdomen and CNS, and no lower limb edema. Baseline ECG before. Then after that, the ECG in ED, as you see, there is cues already. So there is cues already on V1 to V4. So labeled as a late anterior wall MI because there is a cues with pulmonary edema. Loaded with DAPT, heparin, received 40 IV Lasix. He was in pulmonary edema, nasal cannula 3 liters posted. Discussed with interventionist for emergency PCI and decision to take him to cath lab. Discussed with the patient about the PCI, but he refused and he preferred to be in medical treatment. So shifted to CCU, relatively stable, pressure is 105/60, and also the heart rate is a little bit tachycardic. Labs, as you see, the lactate is already 4, and also troponin 407, pro-PMB 1900, LDL 4.3, creatinine was normal. Chest X-ray on ED, pulmonary edema, not looks bad. Then after that in CCU, the patient has heart rate 115, start to drop blood pressure 85/50, respiratory rate 50, 92% on 4-liter nasal cannula and lactate 5. Started on NORAD, dobutamine, and furosemide infusion. Echo showed ejection fraction 23% with no significant valvular disease, and the picture is multi-vessel disease with regional wall motion abnormalities. Contrast echo showed there is no thrombus. 2 years back was normal. So from this, as you see, the patient has process to cardiogenic shock, was impending cardiogenic shock in ED. Then after that, because he refused the intervention at that time, so we went to he went to the cardiogenic shock, almost sky C, D, emergency PCI, discussed with him again, and he was feeling sick, severe shortness of breath, and also he is not tolerating an IV, so shifted to cath lab after discussion with the family, with him, agreed. So he got intubated because he was not tolerating the IV. Chest X-ray, CCU, pulmonary edema, almost flash pulmonary edema. We did coronary angiogram. This is the coronary angiogram. So left main disease and also diffuse disease of the diagonal, and also the diagonal and the circle. And then after that, diffuse disease of the diagonal. As you notice here, so the LED totally occluded before the diagonal almost. And there is retrograde filling from the RCA. RCA, diffuse disease, and also from the distal occluded 100%. So what's the next step for this patient? Patient 66 on cardiogenic shock, sky CD, triple vessel, almost a triple vessel with the left main, LAD totally occluded, diagonals, big diagonal, also RCA totally occluded with retrograde filling from the left system. So what do you think? What's the next plan for this patient?
Ejection fraction is low.
I mentioned it, ejection fraction 23%.
So it's an indication of mechanical support. This is one of the preparation for the patient before any intervention.
Mm-hmm.
So just for clarification, based on the data that you said, patient came in cardiogenic shock. It wasn't impending cardiogenic shock. Maybe it was class B/C, but he was in shock.
Yeah, sky P almost, right, or C, you can say.
Right, so he came in shock. He just deteriorated to C/D. So And of course, at this point, anything you want to do needs to include mechanical circulatory support, depending on what availability you have in the
Okay, so I will go quickly because I run out of the time. So the patient intra-aortic balloon pump inserted, BA catheter inserted, discussed with the surgeon, except for CABG after stabilization, optimization of his condition. This is the main plan after the angiogram. BA catheter, as you see, we right heart catheter for him, low cardiac output 2.8, cardiac index 1.5, and capillary wedge pressure is extremely high, 41, BA catheter 49.
Sorry, can I ask you also?
Yep.
We never saw the LAD. It's occluded, but we never saw the
Yep.
LAD.
Yeah.
So the quality of the LAD, if you send somebody like this for surgery, they're like, I would say probably more than 50% death, and you have no idea what the LAD is like, which is going to be the most important part for surgery. So I would just be a little worried without seeing the LAD.
Yeah, this is I suspect that question because we thought the interventionist before he thought that the LAD is the diagonal because it was very large diagonal supplying the area. Okay, so just I mention it because we proceed after that for the PCI. So nephrology consulted again, a patient anuric on maximum support, SCI C as we said, and D with multi-organ failure, liver enzymes high, and renal also, MDT meeting done, CCU, cardiogenic shock team, interventionist and cardiac surgeon, nephrologist and patient family agreed for BCI, for high-risk BCI and umbilical support. Umbilical inserted. We make sure about the axis, fine, there is no issues with it. Then we we have difficult to cross the diagonal, we cross the diagonal. Then after that, we dilate the proximal LAD. Then mid, almost LAD. The final after dilatation of that, the final after dilatation of these two. Then after that, we went to, we struggle a lot to cross the, we struggle a lot to cross the LAD. Using multiple wires, then balloon support, small support. Finally, we crossed it grand slam wire, and also with balloons, long balloon support, we cross it, and then here is it, the LED appeared, large LED, and then after that we proceed for the diagonal. We IVAS both LED and diagonal. We stent the diagonal. We did IVAS to see the ostium of the diagonal, if it is really diseased or not, need to do kissing or not, but it seems to be not diseased because by the IVAS. So we IVAS it again to make sure everything is fine, so we stent the diagonal. Then after that, we will move to the LAD, left main, so we stent the left main to LAD, another overlap stent with it, and we IVAS it again, and this is the final result, which is shown here. After that, hemodynamics improved, FiO2 decreased 100 to 40%, and Ampulla removed, and intra-aortic balloon support gradually going down and stopped after that. Hemodynamically improved, capillary wedge pressure and CVB also, hemodynamics improved in the cardiac output and cardiac power index. So the patient went off sedation, extubated, and started to produce urine after dialysis, then transferred to the ward, and then creatinine improved, EF 35% with follow-up. The last time I saw him 1 month back, he was asymptomatic. I know that the RCA is still C2O, but we said we will see if it is become more symptomatic, maybe we'll try to refer him to C2O team and open the RCA. So take home message, cardiogenic shock, don't delay, further delay, high mortality, as all colleagues agreed on the previous session. That shows if suitable mechanical support is very important, and the mechanical support is needed with the patient's SCI DC till we fix the reason, valvular or MI, whatever is there. Thank you very much.
Thank you very much.